Hi. So for those who don't know me, I'm Tom Connor. I'm the head of Public Health Genomics in Public Health Wales. And I'm also a prof at Cardiff University. And just to say before I start, I always have these big acknowledgement slide. I'm going to talk to you a bit about some of the services that we provide and some of the work that we've been doing in PHW. But just important to emphasise that the activity that I'm describing is the work of many hands, both within Public Health Wales and also within collaborating partners and organisations. And so just really to acknowledge the fact that we deliver a set of services and we're working on delivering new services, and all of that is kind of founded on collaboration. And I guess where we are as an organisation is looking very much to make use of innovation that comes from the research space and turning that into patient and public benefit. So today I'm going to introduce a bit about PHW, a bit about Wales, and then I'm going to introduce the concept of precision public health and how that relates to the work that we do. I'm going to share some thoughts around how we've built our services and what we do, and then I'm going to, at the end, introduce some of the work that we're doing on to address the challenges of antimicrobial resistance. And I think, as you'll see, our focus to date hasn't necessarily been on new services focused on AMR itself, but AMR and prevention of AMR is very much part of what we do, and we've got services coming which will hopefully start to address some of that in the future. So just a bit of orientation. I am coming to you live from Cardiff, and just to remind everybody on the call, this is Wales. And I work for Public Health Wales. So these are the contractually required slides describing our mission and our vision. If you want the TLDR version, we're part of the NHS in Wales. We as an organisation are responsible for public health activity. We are here to safeguard the people of Wales's health, to reduce inequalities, and to act across the spectrum of public health activity to improve the health and happiness, apparently, of the nation. What we also do, a major part of our activity, is we run most of the microbiological diagnostic laboratories in Wales, and we run the health protection services in Wales that take that action, that use that action in surveillance practice. We provide guidance and lead on things like antimicrobial resistance and healthcare associated infections. And so there are some quite big differences between Public Health Wales and UKHSA in terms of what we do and in terms of the activities that we undertake. I think critical, we provide fully national microbiological and infectious disease services for the entire population of the country, and that's provided through our labs and our consultants who are embedded in different parts of Wales. And because health is devolved, we have our own healthcare system, and that's run by Welsh Government. And within that system, we have an entity called Genomics Partnership Wales that was established by Welsh Government to deliver the development of genomics, that's both human and pathogen genomics, within the healthcare system in Wales. And so we work as a partnership across the system. So Public Health Wales covering the pathogen part, the Oars Medical Genomics Service, who provide human diagnostic services around cancer and rare disease. We have extensive involvement and interaction with patients and the public. We have patient reps sitting on our management boards. We have patient sounding boards that happen multiple times a year, and they're really integral to the development of our strategy and of our approach. And again, the aim is to work as a system to harness genomics to improve the health, well-being and prosperity of the people of Wales. So I work in the pathogen bit, although we have some slightly wider activities. And our pathogen genomics services are delivered by Public Health Wales, and we have fully end-to-end accredited ISO 15189 standard services for C. difficile, for mycobacteria, for HIV and SARS-CoV-2. And then we've got non-accredited or development services covering influenza and RSV, antimicrobial bacterial surveillance and characterization, CF, polymicrobial infection diagnostics. We've got a host of areas of activity covering things like mpox, trying to look at using some of the data that we're routinely generated for other purposes, to looking at mycobacterial outbreaks for species other than mycobacterial tuberculosis. We have a huge amount going on, and that sort of spans the activity, the possible activity within public health and microbiology. And just to sort of summarise that, so we were established in 2017, the genomics capability in Wales, and we had an initial service that was built around developing services for HIV and TB. We had 7 lab staff and 40% of me, and we had a capacity of about 2,000 samples a year. As it stands now, we have probably 35 permanent staff working for the genomics program. We have over 100 people across PHW who make use of our data outputs routinely as part of providing services. And we have a capacity of over 2,000 genomes a week, should we want to or need to flex to that kind of level. So we've seen quite a significant growth in our activity and in our capabilities, and we're really an integral part of the healthcare system in Wales. So why are we here? So why do pathogen genomics at all in a healthcare system or in a public health system? And it's worth just reflecting on the fact that genomics is applicable at many different scales, and so it gives us on a patient level, and we had the example of antimicrobial resistance in a patient just given in the talk just now. So genomics gives us that ability to it gives us a lens through which we can understand disease at a patient level, and it certainly does that. But when we aggregate that data and when we combine that data with other contextual information, we can also look at other scales. So we can understand mechanisms of disease for treatment and prevention. We can look at and understand disease across populations, and we can then use that in our understanding of the organism and of its genomics across its population, combine that with contextual information from the host, and better understand risks across populations. And in public health, each one of these boxes gives you actions that you can take to either prevent disease or better treat disease when it does occur. And so that enables lots of things across the system. It enables things like precision medicine. It enables us to do better surveillance. It enables us to be better prepared for things in future. And the way that I like to think of the genomic services that we build is we don't build a service that's just going to sit in one place. We build a service which is going to generate data, and that data is used in multiple places to ensure that realizes the value that's held in the data for the healthcare system and for patients individually. And that's certainly, there are challenges in that. Some of the ethical considerations and difference between, ethics on a patient level versus public health ethics. But that's something that, as an organisation, we have to deal with kind of on a daily basis. So what does that look like? So, this is just an example of one of our service areas. This is SARS-CoV-2. We can take genomics and we can use that at a patient level to inform treatment. And we do use our SARS-CoV-2 sequences, continue to make use of that or have them available to inform treatment decisions at a patient level. We can aggregate them to identify and manage outbreaks at a hospital level. We can combine data sets across the whole country, and we can use that to infer epidemiological parameters, for example. And then we can take data science approaches. We can render some of those measures of population growth or diversity within the population into a statistical analysis. We can RAG rate that, and we can communicate information to policymakers about if something is getting worse or something is getting better. So same underlying data set, but used in different ways at different scales, and that enables precision public health. And precision public health is the right intervention to the right population at the right time. So that population could be a population of one, the patient, or it could be the full 3.25 million people in Wales. And I think the challenge that we've had in Public Health Wales is we're not a massive organisation. We're about a 20th of the size and budget of UK HSA. So we don't have limitless staff and money. We don't have lots of staff. Most of our staff don't have PhDs. We can't do everything. And there's loads of things that we need to do as part of our routine work that we can't kind of disrupt. And so the challenge that we had and the challenge that I think we continue to have is that there's loads of cool stuff that gets published. There's loads of cool research going on. There's lots of things that it would be really interesting or possibly valuable to do for public health. But how do we go from that idea through to a service? And I think that's the challenge that we struggle with. And it's one of the reasons I think why sometimes it seems as if public health moves more slowly than researchers might expect, because actually taking research and turning that into a service that's going to run 24/7 for the next 15, 20 years is a significant challenge and potentially a significant cost. And so there's quite a lot of work to do that right. And I think the first thing you have to do if you're going to do that is you have to change your way of thinking about services. So in the sort of the diagnostic space or in the kind of laboratory space in healthcare, there's very much this idea that the test is the thing that happens in the wet lab. And that aligns to what happens in most diagnostic laboratories. A sample is taken, a result is generated. That result is pushed through to some sort of laboratory information management system. And then there's an action from a healthcare professional. And in the genomics world, that's not the case anymore, because the actual test is digital. It's the bioinformatics which you're using to generate outputs, and it's the reanalysis and iterative analysis of data and analysis in different ways that enables that data to be used in different contexts, and creates opportunities for action. And so that changes how we need to think about services, and it changes how we need to plan services, and it also creates lots of challenges, because you start to get to this question of how do you interpret data. What if there is a signal in there? What level of something do we need to detect for us to consider that a signal for action? And those guidelines are complex to write, they're complex to work out, and that's why activities such as TARGetAMR, these networks bringing together research, is critical, because we need consensus, and we need expert opinion. We need the research to have been done for us to then develop the guidance that allows us to move these things into service. So, thinking about the system, where does genomics sit in AMR? And in public health, we just think about prevention, or different types of prevention, different levels. So here's a sort of little diagram: primary, secondary, tertiary, and quaternary prevention. And what you find within the healthcare system is different people generally have different responsibilities for these. So primary prevention, preventing infections occurring in the first place. Secondary prevention, detecting the disease early, so early detection of resistant organisms in an AMR context. You could also say that getting the treatment right is a form of secondary prevention, because if you treat the patient that you find that's got the resistant organism correctly, first of all, they're less likely to transmit to other people, so you're preventing that spread. If you do get spread, then we move on to things like preventing transmission and stopping outbreaks. So infection prevention and control is one of the classic examples of tertiary prevention. And then quaternary prevention is avoiding unnecessary medical interventions. And in an AMR space, quaternary prevention is things like good antimicrobial stewardship, preventing people being treated with drugs they don't need to be treated with, which then cause them to develop resistant infections. So just thinking about that, thinking about prevention, just understanding that AMR sits across all of these, and that genomics has the potential to generate outputs that help to guide prevention in all of these areas, which is really important in healthcare. And so what does that look like in practice? Well, I'm going to give you sort of one main example of what we're doing, give you a sense of the type of work that we do and the type of services we run. So we operate a C. difficile typing service. So this service was proposed in 2016, and it followed an investigation of an uptick in C. diff rates in North Wales, which saw a major sort of incident within the health board. It ended up with the chief executive to that health board being forced to resign, and it affected quite a number of patients across that health board. And previously, we used PCR ribotyping to characterize C. diff, and that provided very broad strain level differentiation of patients, and that is a relatively imprecise measure. And so we built a system to replace that strain level characterization using ribotyping with whole genome sequencing, which provides very fine scale typing based on a SNP address. It was initiated between the Pathogen Genomics Unit in PHW and the UK Anaerobe Reference Unit. And it was built as a service with engagement from across the NHS in Wales. And we accredited this service in 2020. So while we were doing our COVID response and scaling our sequencing capacity up to about 7,500 SARS-CoV-2 genomes a week, we were also completing our ISO accreditation for our C. diff service, which sequences around about 4,500 to 5,000 samples a year. So every C. diff case in a hospital in Wales, which flags positive, is sequenced as part of our system, and then we assign clusters, and then there's some sort of action. So it's a multi-part activity. So the organisms are cultured and characterised within the UK Anaerobe Reference Unit, and some of these do undergo susceptibility testing, although that's not a standard thing that we do for C. diff at the moment. We then do library prep and then sequence it. We have a bioinformatics pipeline that runs, that's managed by our bioinformatics team. Samples are then quality controlled and signed off by the laboratory, and we assign at that point a cluster code to each sample, which is a SNP address that identifies that the organism is part of a cluster associated with other C. diff cases. That's then reviewed. There's an element of clinical interpretation that's undertaken by the Anaerobe Reference Unit, and that information is communicated back to infection prevention and control colleagues. If there's additional analysis required, that's raised as a request with the bioinformatics team, and then infection prevention and control measures are implemented by our clinical colleagues. At the same time, we can take that information, we can look at outbreaks, we can look at what's happened in terms of the or what's happening in terms of the spread of disease, and that can then be used by health protection teams for some sort of public health action. So whole genome sequencing is our principal system for prospective C. diff cluster detection. So we detect clusters, and then that then starts the infection prevention and control process. We have a turnaround time of normally 6 days or less. So we're reasonably rapid, and we're pretty effective at catching samples or catching cases. We've sequenced over 20,000 isolates since 2019. And there were over 3,350 samples sequenced in 2023, with almost 5,000 last year. 96% of samples fall into a pre-existing 250 SNP cluster. So that means that 96% of our samples are 250 SNPs or closer to at least one other sample in our data set. And what that means is that we're pretty sure that we're catching most of the sort of the transmission clusters that are occurring, and that then gives us something we can use to understand transmission better and catch it. Data is then fed through into local systems, and this is a system that we use in North Wales. And this data allows for the identification or specification of a cluster of cases, and these are patients. So each row in this diagram is a patient. The coloured blocks that you can see are time spent on a particular ward. So the colours are by ward or hospital, and we can see when samples are taken. And so what you can do is you can define a genomic cluster, you can pull all the patients for that cluster, and you can view where the patients have been. And you can see the second and third patients there actually cross over in time in one of the wards quite early on before both of them flag positives. This is a mechanism to identify where there might be potential routes for transmission and routes for investigation. We can also overlay on this other information. So policy says if you have somebody flagged C. diff positive, they should be isolated. And sure enough, in these cases, we see that those policies were followed. We have had cases where isolation didn't occur promptly after the flag positive, and we can actually show in some cases that transmission actually did occur in the time between when somebody should have been isolated and when they actually were. We can also view, we have e-prescribing in Wales, so we can also view the medicines that have been given to a patient prior to them developing an infection. And you can see that the top example, the top line, that top patient there had a significant number of drugs given to them in the sort of the days and weeks before they flagged positive with C. diff. Many of these actually were antimicrobials, so they were clearly being managed. And what this allows us to do, and this is actually used within the health board, every new C. diff case, they use this information, they review what occurred. They review the actions of the clinical team to identify if there are any learning or feed forward they can take around things like antimicrobial stewardship. And this is a good example of one where actually maybe the patient has been given, a real mix of antimicrobials, elevating their risk of developing a C. diff infection. And there are maybe things that could have been learned from this one, and that would be fed forward to the clinical teams and used as part of efforts to prevent this in future. So that's our C. diff service, and that service runs across Wales, supported by both infection prevention control teams, healthcare epidemiologists, and clinical colleagues. Beyond that, we are currently in the development stage of building our next set of pathogen genomics services, and the one which is most advanced is our AMR project called ARGent. And ARGent is really about sort of secondary and tertiary prevention. So first of all, being able to support management, particularly of resistant organisms, and then also identifying outbreaks early, and then putting mechanisms in place to prevent transmission. This is one that there's not too much I can talk about. I'm happy to answer questions about, but this is one of those services that has been quite challenging to build, because in an accredited environment, you generally accredit for services in a particular scope, and being able to effectively build pipelines, validate and verify them for a wide range of organisms and a wide range of resistance markers is extremely challenging. So this has been a project that we've been working on since probably about the same sort of time as C. diff, around about 2017, and the challenges relate to the sheer range of potential organisms that we could look at. So we have an MVP which is coming, which will cover MLST for any organism with an MLST scheme, and an element of AMR typing from genomic sequence data, with the idea then that we will be adding CG-MLST schemes and more detailed tools for profiling specific species as we go, and this is a service that's currently funded to provide around about 2,000 samples a year, and it's already been used. And the paper on the side there, which was a collaboration with the David Arneson's CGPS, is actually an analysis of Klebsiella data from the ARGent project, looking at some transmission in hospitals in Wales. So I've given you an idea of some of the challenges we've got, some of the work we're doing, some of the way we think about these things. And I think one of the things to note is that a lot of the work using genomics around AMR is still relatively early on in Wales. Our C. diff data has varying amounts of susceptibility testing with it. But even without having direct AMR data, by better managing the disease and understanding things like the inappropriate use of antimicrobials that lead to infections, we're still playing a role in helping to impact the rates of antimicrobial resistance in Welsh hospitals. The next stage for us is moving to sort of an AMR focused set of services based on ARGent, and what we have internally is a modular platform that allows us to translate research activity into diagnostics and service, and our aim is to do that in a real-time way. So with the idea being that we ideally want to be generating results within about 7 days of a sample being taken to enable action to actually prevent transmission. So conclusions. So we've got a set of ISO accredited services in Wales. We're generating a significant amount of genome sequence data. It was something like between 15 and 20,000 genomes last year were sequenced within the unit. We have a set of services. Our C. diff services and our AMR service offering are modest in some ways in terms of the scope of what we're able to do within an accredited environment, but actually the impacts are quite significant. The benefits to infection prevention and control, the data sets that we're building, I think are really quite powerful potentially. And over the coming year, we're going to be adding to our services, and we see significant potential to try and utilize the use of genomics to better respond to and deal with antimicrobial resistance. So lots of challenges, lots of hard work to take nice research and turn it into services, but it's something that we're very keen to try and move forward. So I thank you for your attention and the opportunity to share a little bit about what we're doing in Wales.